Today I'll be talking about the micturations, a bit about the anatomy, embryology, blood supplies, and also the UDS concept. So let's begin with the track first. So we have the brain here with the spinal cord, and we have the bladder. We have the muscles, and we have the external sphincter. Okay, so let's begin. Okay, so in general, we have two systems, the sympathetic and parasympathetic. In usual conditions, when we have sympathetics that takes place at the level of T10 L2. This is something that we have to remember because it's in the MCQs. So this is for the sympathetics. The functions of it is to inhibit the micturations. So what happened is that there will be a relaxations of the detrusor. So it's relaxed, and also what we have here is the contractions of the internal urethral sphincter. This is in the normal conditions. And at the same time, we have the parasympathetics at the level of S2 to S4. Okay, so let's begin with the micturations. Because micturations, it consists of three phases. So the first one is the feeling. Second is the initiation. And the third one is the micturation itself. So what happened here? This is an involuntary reflex. So what happened is here is that when there is a filling of the volumes inside the urinary bladder, there will be the stretch of the detrusor muscles. So when detrusor muscles stretch, there will be an afferent sent to the sacrospinal cord via the pelvic splenic nerves, up to the thalamus and go to the pontine, which is pons is the center of micturations, and there will be informations that send to the cerebral cortex, and the afferent will goes down to the S2 and S4 of parasympathetics. Sympathetic. So S2, S4 of parasympathetic via the hypogastric nerves will gives an afferent and information to the detrusor muscles to contract, and the internal urethral sphincter to relax. And at the same time, this is involuntary, and at the same time, pons sends impulse to the S2, S4 via the pudendal nerves. Pudendal nerves also at S2, S4. For the voluntary, when there is a toilet or there is a suitable conditions to pee, then the informations, the voluntary via the pudendal nerves will goes to the external urethral sphincter, so that the muscles will relax and we can start to micturate. So that will be the micturations. So we have the feeling here, we have the initiations here back, and we have the micturations. And the micturations only occur when the IVP, the intravesical pressure, is more than the MUCP, the maximal urethral closure pressure. Okay, this will be the basis of the UDS. But before that, let's go to here, which is about the detrusor muscles. As we know, the ureter, bladder, vesica bladder, and the urethra is coming from have the same epithelial type, which is the transitional epithelium. This is transitional epithelium, or we call it a urothelial. So as you can see, 90% of the bladder cancer is due to the urothelial CA types. So the adenocarcinoma and squamous cell carcinoma is quite rare as compared to the transitional epithelium. Okay, so let's cut it down here. So we have 4 layers of the bladder. So first we have the mucosa, we have the submucosa, we have the detrusor muscles, and it's only 3, and we have the adventitia. Okay, so now the mucosa layer can be divided into transitional and also lamina propria, which will be one of the staging for the urothelial carcinoma, lamina propria. And we have the submucosal. And the third one is the detrusor. And the fourth one is the adventitia. Okay, so the detrusor, if we look, it is the bladder. So we cut it here. So we're gonna find there will be 3 layers. The inner layer will be the longitudinal muscles, and then the second layer will be the circular, and the outer layer of the detrusor is also a longitudinal muscles, and it has the receptor M1, M2, and M3, which the reason why, if in case of the OAB, we have the antimuscarinic anticholinergic agents. So we have a first line of oxybutynine. It's a very old and classical medications that probably still available in UK because it's the MCQ always have these questions. Second one, quite famous in Malaysia, we have detrositol. It's also an antimuscarinic agent, or talterodine. It has 2 doses, 2 mg. It's a short release. 4 mg OD, usually the extended release. And we have another one is darifenacin, or solifenacin, or vesicare we call it here in Malaysia, solifenacin. Vesicare. And if the patient failed the first line treatment, then probably we can think of the intradermal anticholinergics, or mirabegron, which is very expensive. And probably we can think of other medications like Botox for the OAB. Okay, so let's move further with the blood supplies. So as you know that the blood supplies for the bladder is, there's a lot of blood supply. The mainly is from the internal iliac artery. There will be branches of internal iliac artery, but we'll talk about it later. Not now, but one of the branches is the superior vesical artery. Vesicle in Latin, vesica, it's basically bladder. And then we have another branches from the vaginal artery, and we have a small blood supplies from the obturator, and also from the gluteal. So this explains why, even though in the case of severe PPH, we did an internal iliac artery ligations, the bladder still have another anastomosis, and also the blood supplies from the vaginal artery, and also obturator and gluteal. And then there will be a venous plexus to drain out the venous bloods. And for the lymph nodes also, it's not that difficult to remember. There's an external, internal, and also common lymph nodes. And for the nerves, like what we have discussed here, we have the afferent of pelvic splanchnic, goes up thalamus, pons, and goes back via parasympathetic S2 S4 or hypogastric. And we have the pudendal. So let's talk about the pudendal because it's quite important in part 1. Since we have the sacral bone here, we have the how to sketch it. I just want to show the piriformis muscles, which will attach from the sacrum to the greater trochanter of the femur, which will form into a greater sciatic foramen. And also the lesser one. Lesser. How to spell lesser? Lesser. Okay. And here we have the coccygeal muscles as well. So what happened is that in Pudendal, it comes from the sacral plexus. Sacral plexus, as we know, it's come from the S1 to S4. So it gives to the pudendal nerves. So S2 and S4. So from the S2, S4, it leaves. Let me change. So the pudendal nerve, sorry, S2, S4 will leave the pelvic cavity via the greater sciatic foramen and curves over the piriformis muscles and get back into the pelvic cavity via the lesser sciatic foramen. And this is the ischial spine as a landmark for us to feel for the pudendal nerves, because we have the Alcott Canal here, and it's very important landmark because we want to do a pudendal block. So in the Alcott Canal, we have the pudendal nerves, and it will give rise to the three main branches, which is, can you see? So the three main branches, probably I change the picture here. So just three main branches here. So here we have the inferior anal nerves. So we have the perineal nerves from the pudendal, perineal nerves. And we have the dorsal. So this is the clitoris in female, clitoris. Or dorsal penis in male. We have the urethra here. We have the vagina here, labia, and we have the anal. So it gives the innervations to the external anal sphincter. External anal sphincter. And in the perineal, it gives to the external urethral sphincter, and also to the innervations of the bulbospongiosus and also ischiocavernosus. And also dorsal clitoris or penis. So it covers this whole area. So basically, it is a voluntary, because you can ask the patients to try to contract their external anal sphincter, right? If in Malay you ask, when you did PR, you ask them to kemut, so you can feel the pudendal nerves whether it works or not. And then if you do VE or Kegel exercise, it is something that you can ask patient to actually contract, and also you have the clitoris there. So this is the main distributions of the pudendal nerves. So yeah, we want to talk about the UDS itself. As you can see in the UDS, you're gonna have 4 readings. The first one, second, third. So what you have here, usually we're gonna insert a catheter inside the bladder and also parectally, right, to measure the pressure in the abdomen. This one is to measure the pressure in the vesicle. Okay, so you have 3 readings here, 4 readings here. So you have the PDAT, the detrusor pressure. You have the PVES, the vesicle pressure. Vesica is bladder, and PAPT, pressure. And the last one, you have the cura. So as we know, to interpret this, the first innervations, the first sensation for bladder usually is 150 mils. This also one in the MCQs. And the capacity The normal capacity of bladder is about 500. You can take a range about 4 to 600, but I take 5 to make myself easy to remember. And it can go up to 800. But let's take 500 here. And we have the cura, or the urinary flow. It's about, the normal one is about 20 mils per second. So you have the cura here. So how to calculate the PDAT? PDAT, that detrusor, you have to catheter to pressure to indicate the pressure inside the vesicle and abdomen. So PDAT is equal to PVES minus PDAT. PAPT, abdomen. So you want to see the pressure in the detrusor, you have to minus the vesical pressure with the abdominal pressure. And you have another pressure that we have to actually measure it, which is the maximal urethral closure pressure. Can you see that? The MUCP. So the MUCP, or we can P close, in the UDS usually you can see the P clause, which is the pressure of the closure. It's a closure pressure. So basically it's a PVES minus by the P ura, the pressure here. So how can we remember about the muscles here? So let's divide our perineum. So we have the rectum here, and we have the urethra and also the vagina here. So we know that for the levator ani, we have 3 muscles, right? 3 main muscles, which is I want to talk about this muscle actually. Ischiocaverna and ischiospongiosum. Ischiospongiosum and ischiocaverna. Just remember ischio and caverna. Ischiospongiosum, the other name is ischiocaverna, which is the perineal nerves that goes to these muscles as well. And for the levator ani, we have the puborectalis, pubococcygeus, this is coccyx, pubococcygeus, and ischio. So we have puborectalis, pubococcygeus, and puborectalis. Ischio-coccygeus. Okay, so this is how you can remember. I want to highlight on here. So I think that's all. Thank you.